So the big thing to know about strokes, I think, is the fact that you can have two different kinds. You could have a blood clot that plugs up an artery, That's called an ischemic stroke. You have a blood clot, plugs up an artery to your brain, and then that brain tissue starts dying. Ischemic stroke. The opposite type of stroke, and it's important to realize there's two different kinds. The exact opposite is called a hemorrhagic stroke. That's not a blood clot. That's a bleed in your brain. Inside your skull, you are bleeding. It's called a hemorrhagic stroke. That's a bad situation. The ischemic stroke with a blood clot, we can treat with different things. Probably one of the coolest things is a clot buster. We can give TPA, tissue plasminogen activator, TPA, clot buster. We actually give one called alteplase. That's an ischemic stroke. It's caused by a blood clot. The opposite, hemorrhagic stroke. Well, if you're bleeding in your brain, the last thing you would want is to cause more bleeding, which is what a clot buster would do. I told you I would show you a couple websites. I forgot to do that. Am I screen sharing? Yeah, I am screen sharing. So what I did is I just typed into Google, I typed in current recommendations for stroke. And it took me right out to the American Heart Association journals, specifically the Stroke Journal. And here it is, the guidelines for the early management of patients with acute ischemic stroke. So these are the guidelines that every hospital, every ambulance service, every emergency room, every ICU, every rehab facility are bound by this journal article. It's in this Journal of Stroke. Most recent is December 2019. If you read this whole article, and this article, I downloaded the PDF. Let's see. If you read this whole article, and it's 75 pages long, so it's really long. If you read that, you would hands down be a world-class expert on this one thing, strokes. It talks about everything. It talks about the level of scientific evidence, like how good is the evidence? If it's really weak evidence, we would put it way down here. Really good evidence, strong evidence, we call it a class 1 recommendation. So I'll post a link to this in the announcement later today, but it does cut. Some of you guys might be on a volunteer ambulance squad. If you are, very first thing right off the bat, it talks about pre-hospital systems. So that would be your 911 people, volunteer EMTs. And then it just goes all the way down, hospital stroke teams. And it talks about way down in here, it talks about alteplase. Alteplase is that med I was telling you about. It's a clot buster. So they have whole guidelines based on that. Anyway, that's called the guidelines for the early management of patients with an acute ischemic stroke. Ischemic, remember, just means they have a clot, not a bleed. If you had to have a stroke, if I had to have a stroke later today, I would hope I had an ischemic stroke, because there's a chance they could do something about it. If you have a hemorrhagic stroke, you better hope that you are in a hospital that has a neurosurgeon. If you're in a hospital without a neurosurgeon and you start bleeding in your brain, you're kind of screwed. So not very many hospitals in Nebraska have a neurosurgeon. Here in Lincoln, we do. Bryan West, we got neurosurgeons. Omaha has neurosurgeons. I honestly don't know west of Lincoln how many neurosurgeons we have. Last time I worked west of Lincoln, I worked in Grand Island last, and we did not have a neurosurgeon. So in the city of Grand Island, if you had a hemorrhagic stroke, bleeding in your brain, we had to ship you out. We had to ship you to Lincoln. If you were in North Platte, Nebraska, having a hemorrhagic stroke, you'd probably end up in Fort Collins, I bet. I bet Fort Collins is probably the closest neurosurgeon. Stroke is the 5th leading cause of death in the US, often results in paralysis of one side of the body. And because we have an aging population, the incidence of stroke is increasing. Risk for African Americans is greater. That's definitely true of diabetes also. Native Americans too. And Hispanic Americans. When we think about stroke, the risk factors for diabetes play into the risk factors for stroke. Absolutely. The metabolic syndrome. I didn't really mention the metabolic syndrome, but basically what you have is obesity, high blood pressure, and high cholesterol, and then insulin resistance or type 2 diabetes. All of those are called the metabolic syndrome. Metabolic syndrome. So that diabetes, that metabolic syndrome, that obesity ties into this chapter, strokes. And it definitely ties into the heart attack chapter, all of the other illnesses, really, the leading causes of death. This book talks about basic A&P of the brain, the spinal cord. As far as this slide goes, I would recommend just staring at this picture for a while, trying to think about what those different parts do. The spinal cord runs up into your brain stem, and so that's all connected. Your spinal cord runs all the way down your back to your butt, and that's connected to your brain. It's called the central nervous system. The spinal cord turns into your brain stem, which includes your medulla and pons. The pons and medulla are responsible for keeping you alive. So you can have brain death and still be breathing. And the reason that can happen is the breathing is taking place in your brain stem. Most of your conscious thoughts are taking place in your cerebrum, the top part of your brain. The higher up you go on this picture, the higher up you go, the more human you become. And so most reptiles have a brain stem. Crocodiles, lizards, they have a brain stem. But they can't really think like a human. They can't set goals. and attain those goals. That seems to be a feature of the human brain, specifically the frontal cortex, or the frontal part of the cerebrum, which is the part of the brain right behind your forehead. Right behind your forehead is your prefrontal cortex, and that has evolved in humans to just be dominant. And the most important thing that the prefrontal cortex does, goal setting and goal attainment, but also the mathematics of social functioning. How to be part of a community. That is all taking part in the human part of your brain, which is the cerebrum, and especially right behind your forehead, the frontal and prefrontal cortex. If you think about how your brain differs from your cat's brain, your cat doesn't have much of a frontal cortex. And that's why he's a jerk. And he's secretly trying to kill you. Because your cat is not any good at social connections and social engagement. But the human brain, that seems to be what it developed to do. So the farther down you go, the more in common we have with other animals. The cerebellum on the back side of the brain, which is just right above your neck, really, that cerebellum is mostly responsible for movement, fine motor control, starting an IV. That's the cerebellum. Setting goals and attaining those goals, like setting a goal to study for this exam, is taking place in the frontal cortex. As you can imagine, if you have a stroke that kills off any part of the brain, you will have a deficit in the corresponding function of that part of the brain. If you kill off your brain stem, you're immediately dead, because your brain stem is keeping your heart going and is keeping you breathing. If you have a stroke that kills part of your cerebellum, well, now you have motor control problems. You probably are still thinking clearly, but you can't really control your arms and legs very well. The book does talk about the spinal column. The concept to know here is that a lot of your nerves crisscross. And so oftentimes you have a stroke on the right side of your brain, you could have symptoms on the left side of your body. So you have that crisscross. And this slide kind of demonstrates how that works. And it's not true of every single nerve, but the large majority do crisscross. And so you have a stroke on one side, you have weakness on the other side. And a stroke being up here in your head, and the weakness being down in your arm, down in your leg. That's because those spinal tracts. The cerebrum is the uppermost region of the brain. You have a right and left side, and that right side is connected to the left side via the corpus callosum. The corpus callosum is the connection between the right and left side of your brain. We think that the left side is a little more important for things like language and math, using math. The right side seems to be a little more important in face recognition, music, emotion processing. Emotion processing seems to happen more in the right side of the brain. So if you have a stroke on the right side of the brain, you can have weird symptoms and emotion processing difficulty. Stroke on the left side of the brain, math difficulties. I think that's probably, I played high school football and I probably got hit on the left side because I can't do math. Terrible at math. That's the left hemisphere. You can have a stroke that affects your speech area, Broca's area specifically. If you have a stroke there, you have a fascinating symptom called expressive aphasia. And that's a really neat symptom. I just think it's fascinating. I've always enjoyed patients with expressive aphasia. And I took care of a nice lady in the nursing home years ago. She had just had a stroke, didn't really affect anything except for her speech capabilities. And if she wanted to go to the bathroom, she would point at the toilet and say, "Give me my toothbrush." And we knew that toothbrush meant toilet. She would just always have expressive aphasia. Expressive aphasia is fascinating and usually pretty obvious. You can usually tell, like, oh, yep, they're mixing up words. But receptive aphasia, you can't really pick up on it as easily, because when you say a word as a nurse, you say, "Would you like your toothbrush?" The patient hears a different word. So they might hear, "Would you like the toilet?" So receptive means they're hearing a different word, receptive aphasia. Comprehending language is a problem. That's a different part of your brain, and you could impact it with a stroke. There's other pictures of your brain in the book. Your visual center is the back of your head. Have you ever got hit in the back of your head with something, or maybe fell and hit the back of your head and you saw stars? That's an example of a hallucination, technically. When you see stars, because there's not really stars out there, but you got hit in your visual area of your brain, that's called your occipital lobe, back side of your brain. Your cranial nerves originate in your brain stem. There's 12 of those. They all do something different. If you take human anatomy and physiology, you'll have to memorize the 12 cranial nerves. I remember memorizing that in school. I was led to believe that that would be something I would use in my nursing career, but I have to say that I've never used any of that. The nurses that do use the 12 cranial nerves, and they're really good at assessing each one, are the ICU nurses that work specifically on a neuro ICU. So if that's something that interests you, be a neuro ICU nurse and you'll learn how to assess all 12 cranial nerves. But for the most part, though, the average nurse, we don't really do that at the bedside. The cerebellum is that back part of the brain, right above your neck, and that's responsible for smooth movement. If you have a stroke in that part of your brain, you could have an ataxic gait. Ataxia just means uncoordinated walking. Ataxia is always something we have to treat seriously, because it could mean your patient is having a stroke. You have different arteries that feed different parts of the brain. The artery to know, because 80% of strokes take place here, is the middle cerebral artery, the MCA. If you do clinicals on the 3rd floor at Bryan West, that's the rehab floor. All of the stroke patients go to the 3rd floor rehab, and then eventually they go to Madonna or a nursing home, depending if they need that. But most all of your patients on 3rd floor rehab have had an MCA blood clot. They've had a blood clot in the MCA, and that you'll see that all the time. The doctor just abbreviates MCA, middle cerebral artery. Well, that one artery perfuses 80% of the brain's tissue on that side. So you imagine this could be pretty catastrophic. At the base of the brain, if we were to just pick your brain up outside of your skull and turn it over, we would see the circle of Willis. And that circle of Willis, this slide kind of shows a picture of it, and that picture's in your book too. The circle of Willis it's nice because being a circle means that you have collateral circulation. So if one part of that plugs up with a blood clot, hopefully you get blood coming around the other direction, perfusing that brain tissue. So you don't get as much of an area of brain tissue dying. Sometimes you will hear about subarachnoid hemorrhages or aneurysms that burst. Often an aneurysm in the brain takes place in that circle of Willis. That's a bad situation if you have a blood vessel pop in the circle of Willis. This is just a close-up of the MCA, middle cerebral artery. That's perfusing up to 80% of that side of the brain. We do not want a blood clot in there, but 80% of blood clots or strokes do take place right there. This talks more about the circle of Willis. It's a common site for aneurysms. And we think for the most part, those cerebral aneurysms have a genetic component. And again, the treatment for that, if it ruptures, you better hope you're in a hospital that has a neurosurgeon. More recently, in the last 5 or 10 years, our interventional radiologists have been starting to fix these as well. That's really exciting because we have a lot more radiologists in Nebraska than we do neurosurgeons. So an interventional radiologist, he might run a catheter right up in there and potentially be able to fix that. Those cranial nerves, you do have 12 of those. They all do different things, like cranial nerve number 1, your sense of smell. The one that I'm most interested in, cranial nerve, that I've studied the most over the last 5 years probably, would be the vagus nerve, cranial nerve number 10, because the vagus nerve runs from head to toe and it innervates your heart. The vagus nerve innervates your heart. So that's one of those cranial nerves. Very important. Your brain is the most energy consuming organ in the body. It requires or uses 20% of the oxygen that you breathe. With each breath that you take, 20% of that breath is fueling your brain. They're not really capable of anaerobic metabolism. They really require glucose for energy. We think that Alzheimer's disease is a problem with glucose being utilized in the brain. And so that's why some doctors call Alzheimer's disease type 3 diabetes, because your brain tissue needs sugar for energy. Hypoglycemia, which is low blood sugar, hypoxia, which is low oxygen, both can affect your brain functioning. So here on this slide, it mentions that 85% of strokes are ischemic, 15% hemorrhagic. Hemorrhagic means you're bleeding in there. You're bleeding inside your skull. A TIA, everybody always says a mini stroke is an inaccurate label, but we still use it all the time because that's what your patient will understand. Most patients will say, I've had many strokes. I've had many strokes. And what that is somebody presents with stroke-like symptoms, and then the symptoms just quickly go away. They just go away. It's like, oh man, they didn't have a permanent stroke. They had a TIA. But somebody that has a TIA, high risk for having a real full-blown stroke. So we have to take TIAs very serious. It usually means they're working on their first stroke. That's how I think of a TIA. They need a whole brain workup. And one workup that we do is a carotid ultrasound. We take a little ultrasound device and we scan those neck arteries, the arteries in your neck. And what we're scanning for is this plaque buildup. And we can just see that with an ultrasound. You get that plaque buildup in the carotid arteries, you're going to have a stroke. You're going to get a blood clot. Plug that up. I think we talked when we were discussing the heart stuff, the AFib. AFib can cause a clot to break loose and travel up to the brain. I noticed a lot of you guys said that in the discussion or case study for this week. And that's absolutely true. That's why we worry about the heart rhythm called atrial fibrillation. Start fibrillating, they develop blood clots. That blood clot can shoot off, head up to the brain, plug up an artery, kill off a part of the brain. Everybody that's an AFibber needs to be on blood thinners. We got to get those AFibbers on blood thinners. We usually give them aspirin, but also a second one like Plavix or any of those other blood thinners. When the book talks about glutamate toxicity, all they're really trying to explain, which I don't feel they do a great job, they're just trying to explain cell death. What does that cell look like as it's dying? And I would say, do we really care? No, we don't care. We don't care about the glutamate. We don't care about the sodium ion channels and calcium. What we care about is the fact that this cell is dying. The cell is dying. The reason it's dying, it's not getting any blood flow. Not getting any blood flow because there's been a blood clot somewhere. That's what we care about. The cell tissue is dying. A couple slides back, or one slide back, I kind of skipped over it, but what this looks like is a core of ischemic tissue. That's the dead tissue. The dead tissue, that necrotic black center. And then the penumbra is sort of this circle that's a bigger area. And hopefully, if we get this stroke treated quickly, hopefully that tissue will reperfuse and stay alive. It will stay alive, hopefully. So glutamate toxicity is just talking about those cells that are actually dying. When the cell finally dies, calcium floods into the cell. Calcium floods into the cell and now it's dead. The cell's dead. A lacunar infarct, you might see this word. We see a lot of these on third floor at Bryan West. But basically those are pinpoint small infarcts due to occlusion of tiny blood vessels. So lacunar infarcts are often kind of widespread, but little tiny infarcts, depending on how many you have, they can be very catastrophic. Or I've seen some patients who don't seem to hardly be bothered by them at all, depending on how big it is, how many brain cells they killed off. The hemorrhagic strokes is when you have an artery rupture that results in bleeding. High blood pressure is the most common cause. High blood pressure. You bop that blood pressure up way too high, bam, rupture an artery. We see this happen in our alcoholic patients very often. Are alcoholic. If you are a daily drinker, if you drink alcohol every single day, and then you decide to yourself, this ain't healthy. I gotta stop drinking. And you try to quit drinking, alcohol withdrawals are very dangerous. For somebody that's dependent on alcohol, when they try to quit drinking, they can just skyrocket their blood pressure. And it's not uncommon for them to pop a blood vessel in their brain, and they present with a hemorrhagic stroke. The other reason these guys, the alcoholic, they tend to bleed in their brain is because alcohol shrinks your brain. We think that's why when you drink a lot, you get a hangover. You know, in the morning you wake up and you're like, oh man, I got to remember never to do that again. I have a pounding headache because alcohol causes brain shrinkage. As that brain tissue shrinks down, your brain tends to rattle around inside your skull. It's rattling around inside your skull. And it's not uncommon to see somebody with alcoholism fall, and it's a minor fall. They don't hit their head very hard, but the brain ricochets around inside their skull and tears a blood vessel. And they present to the hospital with a subdural hematoma, is an example of a hemorrhagic bleed in your brain. The other bad thing that can happen from a stroke is cerebral edema. Cerebral edema means your brain is swelling. So as brain tissue starts dying, either from a hemorrhagic or ischemic stroke, the brain tissue that's dying very often starts swelling up. That's called cerebral edema, which can make the stroke even worse. If the cerebral edema gets really bad and you start having an increased pressure inside your brain, it's called increased intracranial pressure, ICP. You could have Cushing's triad. I'm trying to think if there's a test question on this. Cushing's triad, pressure on the brainstem. If you can memorize these three symptoms, bradypnea is a slow breathing, bradycardia, slow heart rate, but then hypertension, sky high blood pressure. The Cushing's triad, I think, is a silly thing to memorize because a much more effective assessment to make is ask the guy how he's doing. If you can imagine somebody who has pressure on their brainstem, are they going to be talking to you? No, this guy is not responsive. That's a much better assessment to make. So when you call 911, if you're at a nursing home, I called the 911 last year from a nursing home for this exact thing. Don't tell the 911 dispatcher, oh, he's got Cushing's triad, bradypnea, bradycardia, hypertension. They don't care. The dispatcher will say, is he conscious? And you'll be like, nope, not conscious. She'll say, is he breathing? And you'll say, real slow. And that's how it will page out on 911. We got unconscious, slow breathing. Ambulance is on its way. So Cushing's triad, your patient is unresponsive at that point. He's FTD. FTD is a standard medical abbreviation. It means fixin' to die. FTD. This guy, he's FTD, fixin' to die. And so anyway, Cushing's triad. Every once in a while you see a test question that asks about it, but risk factors for stroke, same as risk factors for heart attack. High blood pressure, high cholesterol, diabetes, smoking, obesity, all those things. The problem with an ischemic and hemorrhagic stroke is they present exactly the same. They look exactly the same. They might have deficits on one side of the body, slurred speech, vision loss. Since they present exactly the same, we have no way of knowing how to treat them. This is how they present. This is the American Heart Association. And the Stroke Association wants you to memorize the FAST acronym. Facial droop, one side of their face just sagging. You'll notice their mouth looks crooked. One part of their mouth is just sagging down in a frown. Arm weakness, speech difficulty. This is when you call 911. If you remember those three symptoms, facial droop, arm weakness, speech difficulty, that will capture over 90% of patients having a stroke. So if you're having dinner at your grandma's house and suddenly she drops her fork and her arm slumps down in her lap, arm weakness. And you look at her face and her mouth is frowning, but just on one side, facial droop. You ask her how she's doing and she mumbles. Call 911. Call 911. But we still don't know, is she bleeding in her brain or did she have a blood clot? We don't know that until we do one thing, one vitally important test that we have to do as fast as possible. And that's a CAT scan. We get them to the ER. The ER knows she's coming because the ambulance called ahead. They might not even stop in the ER. Straight from the ambulance garage into the CAT scan machine. We scan her brain. What we're doing is we're hoping her CAT scan is negative, because a negative CAT scan means we didn't see anything bad on it. And that means she's not bleeding. We can't see the blood clot. We can't see an ischemic stroke, but we know she's not bleeding. So now we can give the clot busting medication. Facial droop, arm weakness, speech difficulty, call 911. 911 will call the hospital and say, hey, we got a stroke coming in. If you're in the hospital, you'll hear overhead, they'll page, we've got a stroke coming in. Both hospitals, Bryan and St. E's here, call it something slightly different. I think St. E's calls it a stroke stop, something. Anyway, stroke alert, ER, ETA, 5 minutes. They'll page that overhead. And the CAT scan tech is dragging whoever's in the CAT scan machine out, because that stroke takes priority. Ambulance screeches up. We unload the patient and run her back to the CAT scan, looking to see if she's having a hemorrhagic or ischemic stroke. So the CAT scan without contrast, and then we start working from there. The TPA, the tissue type plasminogen activator, is that clot busting drug. Not all stroke patients are candidates because we have to use it within 4 hours since the beginning of symptoms. So what happens if grandma wakes up in the morning and calls you and says, I think I'm having a stroke? If she wakes up with her symptoms, we don't know what time they started. Could have been any time during the night. And that's a very common scenario. They wake up with their left side completely numb. We can't give TPA because we can only give TPA within 4 hours from the start of symptoms.